thank again our sponsors, and particularly the California Healthcare Foundation, our presenting sponsor, our platinum sponsors, who you can see here on the slide, Zoma, Cigna, and Sage. Thank you so much. And our gold sponsor, Hope Lab, who hosted our Mom Tech lunch yesterday, we're calling it. So thank you, Hope Lab, and our supporters, Mommy Hannah Institute, and Maven. And on that note, I would like to invite one of our gold sponsors to the stage and invite Stuart Hart to the stage. She's the head of patient advocacy at Sage Therapeutics. Thank you again for all of your support over the years and for sponsoring the forum again this year.
I am Marjorie Stewart Hart. I'm the head of patient advocacy at Sage Therapeutics. I'm actually here with several of my amazing colleagues, Brian, Lily, Zach, and Danielle. So if you see them or if you guys are out there, give a wave. I'm really so proud of the people that I work with at Sage and the passion that they have for this work. This is actually my third forum. I shared last year how nervous I was the first time because I really knew nothing about this. I was about a month into my job at Sage. And Sage was actually in the process of developing the very first therapy that was indicated for postpartum depression, which is actually available for moms. This was my first introduction into the PMEDS community, and so I can't think of a better place where I could have started. And importantly, this was just my first step into this journey that so many of you have been on for so long, into really understanding the importance and criticality of maternal mental health. And I'm really grateful and honored that you've invited me on this journey with you. Sage is honored to be on this journey with you, and we're looking forward to continuing long into the future. My team and I are so grateful that this happens at the beginning of the year, because what this has turned into for us is the place where we get our fuel and our motivation, because spending these 2 days with you reminds us and grounds us in how important the work that we are doing really is. So we're grateful for that, and we bring this motivation and our excitement from this meeting back to all of our colleagues at Sage, and they're so appreciative of all the work that you're doing as well. You know, this year's theme could not be a more appropriate or powerful call to action. We can do more gives us the time to honor how far we have come, and that's due to all of you in this room and so many others. But it also inspires us because we know that there's so much more than we can do. Sage is really so proud to stand with 2020 Mom and all of you, and we remain committed to making sure that moms can get the treatment they need with the urgency they deserve. So thank you so much for allowing us to be a part of this, and we're looking forward to a wonderful day. And now it's my distinct honor to introduce you to the moderator of our next panel to discuss peer support for all of us. Rebecca Alderfer is a senior program consultant leading the area of perinatal mental health at Zoma Foundation. Rebecca began her career at the White House Office of Management and Budget in Washington, D.C., where she shaped policy and funding direction for a portfolio of multi-billion-dollar international aid programs. This work progressed to leadership roles in innovative programs with the State Department and at the Global Fund to Fight AIDS, Tuberculosis, and Malaria, managing staff and relationships with international colleagues in a dedicated effort to prevent and treat infectious diseases. Later, Rebecca joined the Pew Charitable Trust, where she served as a strategic advisor for new philanthropic investments. Relocating to Colorado, she joined a Denver-based health policy institute called the Colorado Health Institute, focused on informing policymakers and leaders on health and healthcare issues in Colorado. Rebecca is also a partner with Social Venture Partners in Boulder County. She is a Boulder County Leadership Fellow alum. She earned a Bachelor of Science degree in economics from Iowa State University and a master's degree in public policy from the Humphrey School of Public Affairs at the University of Minnesota. So she sounds like just such a slacker. My goodness. So please join me in welcoming her to actually get this panel going. Thank you.
I have never had anyone read my whole bio, and that is, it's a little, wow. So thank you very much, and thank you to everyone who's here this morning. As they read, I'm here representing the Zoma Foundation. I'm a senior program consultant for them. The Zoma Foundation is based in Denver, Colorado, and we've been working on changing the way perinatal mental health is addressed and prioritized in Colorado for over a decade now. And I have to give a shout out. Last year I was watching this forum from Denver Health with a whole bunch of colleagues, and right now they should all be gathered at Clayton Early Learning in Denver, Colorado. Hello, everyone. We have an absolutely amazing, dedicated, huge group of collaborators and stakeholders in Colorado that are all focused on perinatal mental health, and they're doing amazing work, and it's an honor that I get to be with them all the time. So the Zoma Foundation is focused on all expectant and new mothers are screened for perinatal mood and anxiety disorders and have access to critical information sources and support from appropriately trained professionals. That's our North Star. That's where we're headed in Colorado. And what about our involvement in peer support? Why am I moderating this panel today? So I was approached by Dr. Sonya at the University of Colorado School of Psychology, who's done a lot of work around behavioral activation across the globe, primarily in India, and was really focused on how we bring the tools of behavioral activation and the idea of using community members to help support the mental health process and wellness across our state. So, as you heard, having had experience working with global infectious diseases, I understood that using all of your assets in supporting health, whether it's providing antiretrovirals or bed nets for malaria across Africa, or using community members and laypersons in Colorado to help support the mental health of our population with folks that look like you and speak like you and really know what you've gone through. So we started on this journey, and now we're going to share and have an amazing panel of folks that are going to share what peer support is really about, what it looks like in action, and we hope you have lots and lots of questions for us about how this model works and what are some of the things that maybe we still need to even learn. So let's dig in. We heard a little bit about peer support yesterday in the parity panel. It came up. We heard about it again in the tech lunch. So I'm going to give you just a few seconds of what is peer support so that we all kind of have a grounding going into this conversation. So a couple of organizations have outlined for you what peer support is. So Mental Health America talks about this being an evidence-based practice, that it's really focused on sharing of similar experiences, and they have seen improved outcomes and quality of life, reducing hospitalizations and the cost of care. SAMHSA also has outlined what they see as peer support, and it really encompasses a range of activities, which we'll talk about later. Again, the core pieces are having shared similar experiences. It's about empowerment, connection, and hope, really giving people the opportunity to hope. If you go on SAMHSA, the SAMHSA HRSA Center for Integrated Health Solutions page, there's a whole document about peer support specialists. If you go on NCSL, the National Conference of State Legislatures, there's a whole fact sheet about peer support that can give you a lot of depth around what this looks like in states and what it looks like from the federal government's perspective. So is peer support recognized by the federal government? Yes, it is. And it has been for a while now. So HRSA, the Health Resources and Services Administration, SAMHSA, which is the Substance Abuse and Mental Health Services Administration, and CMS, the Centers for Medicaid Services, all recognize peer support. CMS has recognized it since 2007. So what does it mean to be certified? What is a certified peer specialist? Certification means that you've had training, that you've had training that gives you certain sets of competencies so that you are an actually informed and helpful peer, and that you have retained that information. So there's usually a test that goes along with it as well to know that you actually have those competencies and can recall them as needed. Every state has a specialized certification process except for California. And Joy tells me that that's coming. So So potentially every state in the union will have one soon, but it looks different across states. Some states have certified peer specialist programs that focus on a broad set of mental health issues. Some have them specifically for substance abuse issues, and some have it across kind of a whole spectrum of different mental health issues. And the really big question is, what about payment, right? How do you support these models and sustain them? And we're going to dig into some of that during the panel as well. There's at least 36 states, and the numbers vary depending on which fact sheet you look at, but it's somewhere in the high 30s. States offer reimbursement, usually through their Medicaid program, although some states have grant-funded programs that are run through different departments than maybe their state Medicaid agency. Again, it looks a little different depending on where you sit. And then what do peer specialists do? They do a lot of things, and the folks that are going to be talking to us on the panel will get much more granular around what it looks like on the ground. But there's really kind of 4 pieces to this, as outlined by the federal government and other standards. It's around emotional support, right? There's the empathy and the connection and the knowing that you know piece of peer support specialists. It's informational. There's resources and education provided. It's instrumental in providing support, helping people identify what it is they need in that moment, and then figuring out how they're going to get to that support. And then it's affiliational as well. So connections to community resources, support groups, helping share events or ways that you can get out and be a part of some of the other things that might help you along your journey. And is perinatal mental health ripe for certified peer specialists? I would posit that the answer is yes, and I think our panel would probably say the same. But we'll have a good conversation about that, I think, and here's why. We talked a lot about provider shortages yesterday and how hard it is to find the kinds of support that have been trained in perinatal mental health. We also talked about stigma, and so if you have the opportunity to sit with someone who looks like you and talks like you and has been through the kinds of things that you're experiencing, it's a huge boost. Enhancing the cultural competency in care and having that opportunity to draw from different communities. Increasing access in community. We talked about access to care and what that looks like, and it's getting outside of the 4 walls of a clinic or a hospital. It's getting out into people's homes, it's getting to the parks, it's getting to the libraries. Cost-effective expansion of services and supports. Peers are a fairly low-cost workforce, and again, we'll get into some of the payment and the reimbursement, and then providing meaningful career pathways for mothers and others that have experienced this and wished that they could do something for others now in this field and be a part of the system that's helping to support mothers. So today, we're going to hear about a few different programs. So first, we're going to invite Lisa up to the stage, and I'll tell you who Lisa is in a minute, to talk about a study that 2020 Mom did around piloting maternal mental health training for peer support specialists. And then we'll talk about the Women's Health Innovations Program in Arizona that's really doing it. They're on the ground setting up and standing up a program in peer support specialists. I'm going to give you just a brief overview of Alma, which is the program in Colorado that we've been working with a lot. And sadly, the 2 leaders of that program in Colorado could not be here today, but we'll share just a few snippets. And then Sister Circles is a peer support model that is also ramping up in California. And then we're also going to hear from a peer herself and her experience and life story that led her to become a peer. So I hope you're excited about this panel, and we'll get started. So I'm going to ask Lisa Melchior, I should have asked you how to say it, who is a PhD and president of the Measurement Group, LLC, and it's a California-based group that works on behavioral health and social science, and she was the lead on the maternal mental health peer support training study. Lisa, please come on up.
So as Rebecca mentioned, I'm Dr. Lisa Melchior. I'm president of the measurement group. We're here in Los Angeles, and we work with behavioral health programs to evaluate their programs and disseminate what we learn from that. I want to thank Michelle Quezada, who's here in the audience, who helped a lot with this study, and also Jackie Gelfand previously contributed as well on our team. So I'm a research psychologist by training. And this project, I was so excited when Joy approached us about helping to do this pilot study because it seemed like just such a really great idea and a very unique opportunity. The pilot training and the evaluation were supported in part by a grant from the New Venture Fund, the Hope and Grace Project. I'm going to give you a very, very brief overview of just what we were looking at in the study and to help set the stage for the other panelists. And the report that is the basis of the presentation, I believe, is in your meeting app, and if it's not now, it will be by the end of the conference. So this is just a basic overview of the peer support specialist training model that we were looking at. It was a two-component training. So as Rebecca discussed, there's actually pretty strong evidence base for peer support as a modality. And so there are established trainings that have worked with people in various behavioral health capacities to help teach soft skills, things about working in a service provider environment that are not specialized to any particular condition. And that's the peer support specialist component. The participants went through a 2-week training that was provided by Recovery International. And then the maternal mental health component was specific to content related to maternal mental health, working in maternal mental health settings, and that was a 2-day follow-on training. Because this was a pilot test, the numbers were very small, and this was really just an exploratory study to find out how people just get some feedback about the training, and then later on, if they had used any of the information. Again, very small numbers. It wasn't really possible to do an experimental design, but we really just wanted to get some feedback about the training to see if and how it was used to provide maternal mental health peer support in community service settings. So this is some data from the feedback we got immediately at the end of the peer support training, and the feedback was, very, very strong. People said they really got a lot out of it, and if we looked at just some, pre and post retrospective ratings, the participants did say they increased their knowledge, both generally about peer support and specific to maternal mental health issues, increased their confidence to go do work in the field, and specifically, again, for maternal mental health issues. They showed promise for really advancing this field through specialized peer support training. People found it useful. We have examples of how it impacted maternal mental health peer support, impacted people not only in their work, but in their personal lives as well. Some challenges were identified. You'll hear, I believe, from Michelle and other panelists about the supports that are involved in having peers on staff doing maternal mental health services, and that clearly there was a need for ongoing support. The other thing is it's wonderful that some agencies do have a clear professional path, but it's not always clear in a lot of different settings, so that came up as well. Some of the things we learned about doing maternal mental health peer support training within the broader context of peer support training was that this really is a specialized population, and that the trainings need to address that as well. Joy has mentioned that her original hypothesis in doing this training was that maternal mental health peers are a unique population with unique needs, and that was definitely supported by the pilot test. So some of the recommendations that are outlined in the report have to do with having opportunities for resources and networking beyond the trainings, having gender-specific trainings because this really is a gender-specific issue, integrating the maternal mental health content within the broader peer support issues, and having mechanisms for support and guidance post-training. Now, I believe Joy is going to come up and kind of set the stage for the next part. Thank you.
We will go ahead and walk through them, and just want to thank again the measurement group for their leadership in conducting this study, and also for those who participated in it, particularly WHI, Michelle and her team, who were boots on the ground administering the training program in 2 states, Arizona and in Texas for us, even though they're just based in Arizona. So thank you for that project management role that you played as well. Again, the hypothesis for the study was that these existing training programs that are in place in every state should be utilized and could be utilized for maternal mental health, but that there might need to be some modifications to those programs, just like there have been modifications for programs for veterans, for example. And so next steps, we know now that this is the case, and so what are we going to do? How are we going to roll out a program that's unique to maternal mental health? And we have been invited by Cigna to apply for a grant to start work here in California, but eventually expand that work outside of California to allow this model to be proliferated. And that means that we're going to be creating a in-depth training. We did a nice maternal mental health training with Michelle's help at WHI. We want to create a online training program that can be downloaded and refreshed annually for peers who go through this certification program. We're also looking at ways that we can help employers like clinics and hospitals learn how to find certified peers to address maternal mental health needs, and then support those employers by connecting them through an online collaboration platform so that those employers can talk about things that they're struggling with, employing peers, and also remind them how they can bill for these services through Medicaid in their states. So with that, I'm going to turn it back to Rebecca, and we're going to introduce the other panelists.
So we've already met Lisa from the measurement group. Next, we have Michelle Lacy, who is the executive director of the Women's Health Innovations of Arizona, which is a licensed outpatient treatment center and nonprofit specializing in maternal mental health care. We have Hasana, who is the founder and CEO of Hasana 9 Exchange. Hasana is a peer support specialist and also a survivor of pregnancy loss, and is going to share some of her story and background. And then we also have Sonya young Aadam, who is the CEO of the California Black Women's Health Project. So give a round of applause for these panelists, and we'll get started. So I'm just going to ask, we kind of broke this up into 3 sections. The first section is models of peer support. Let's learn a little bit about the models. And then we'll talk about the experience of being a peer, and then we're going to just open it up to our questions that I have some planned for you all. And then we'll hopefully hear a lot from the audience and folks that are watching across the country. So I'm going to start with Michelle. Michelle, can you share how the peers that were trained in the 2020 Mom pilot are being utilized at your organization, and about the implementation? And you can also just tell us a little bit about all that you do and the work of the center.
So we, at Women's Health Innovation of Arizona, we are truly service-oriented. Many of us in our organization came from the substance use treatment field where we used peers. And because our organization specializes in maternal mental health, it made a lot of sense to us to utilize peers to help bridge the gap. And so the peers that we have are going bedside at 2 hospitals in our community to provide support and education to those moms who are identified at risk. And honestly, we work really closely with the hospital staff, so the risk could be pretty loose. It could be really tense in the room, and that can be an indicator to get someone to come over bedside. Due to a contract and a grant that we have through Dignity Healthcare, we are able to have a peer on site at one of the hospitals twice a week. And then she follows up 2 to 3 weeks later to just see where things are at and connect her to services. We also have our peers in a community agency in downtown Phoenix who provides bilingual services, peer support services, a group, and parenting. And what we're finding there is that we have grandparents that are help raising their grandchildren. They did not have their perinatal mood and anxiety disorder treated. And so now it's reemerging as in their role of grandparent. And they're able to share it with our peer. And we just had some feedback from one of our moms there that said this program has allowed her to have a freedom that she's never had before, because she can talk about the pain and the struggle that she went through without the shame. And this is really exciting for us, because this is why we do what we do. We have a strong belief in that we need moms to get services. Our peers, though, are part of our therapeutic team, and we will provide extra training and supervision 2 hours a week with our entire team. And then we have individual supervision with our peers. Our peers are going in home and bridging the gap. So I know we kind of talked about sharing a story, but we had a mom who was really struggling with a pretty significant trauma history, and there was a big stigma against counseling or seeking out mental health care, but she was okay with our peer coming into her home. And through the relationship that she was able to develop with that mom, we were able to get her into services, and now she's doing trauma work. So that's how powerful our peers are and how we're utilizing them. And I don't even know if I answered your question, but I'm pretty passionate about this topic, so.
You did. Next we're going to hear from Sonya. And Sonya, tell us more about Sister Circles, and also tell us about your organization and some of your background. We want to hear about Sister Circles, we want to hear about peers, and we also want to hear about the communities that you work in.
I'm very happy to be here, and I certainly appreciate the invitation and the opportunity to come and to speak with you about the work that we do at the California Black Women's Health Project. And I have to say this as a sort of a preface to my comments going forward, that I am not always accustomed to speaking in audiences that are not as diverse, because the work that I do is very, very directly centered and focused unapologetically on Black women and girls and families in the state of California. So, thank you. So I do want to acknowledge that last night, for those of you who were at the dinner at the Standard, that there was one lady who did speak very passionately about the issue of equity. And she asked that we hold, I don't know if she's here in the room this morning. Yes. I wanted to run up and give you a hug, but I wasn't sure if you'd say, okay, that's too much. We're on. Okay, so I wanted to just raise that because the discussion around the issues of equity and the issues of acknowledging where there are gross disparities sort of across the board in the areas that affect Black and African American women, our general health, our mental health, and our perinatal mental health, and our health in general. So I would normally spend time sort of unpacking a history of issues and challenges that, begin and end with racism, structural inequities that exist in systems, that exist in our society and in our institutions. And I would talk about that, and I would bring that knowledge to the forefront in an audience that might be more diverse in this. But I want to respect that not every audience is working closely with Black and African American communities or marginalized communities. Not every person engaged in their work spends time in this area. And so to give you all of that history and to spend time doing that, it might not be helpful. If you're in North Washington State and there is a population that, is one, thank you, we had this conversation yesterday. A population that, might be 1%. This is not necessarily an issue that might be at the forefront of your life every day. So I'm going to just say that. And then also, when we begin to have conversations that go deep and talk about disparities and the reasons why our work is so important, generally there are more people that look like me in the room. And then when we unpack these things, they're very deep, they're very emotional, they cut deep and hard. And then, there wouldn't be enough in this room to help me repack it so that I could go home and face my family and have the rest of my evening without spending it in tears. So I see my dear sister, Miss Winona Valentine, with I Dream of Health Equity and Racial Equity in the room, and I appreciate that she's here and a few others, and we do this work together in LA County and around the state of California. So I appreciate that you're here, and I know when I'm done I could go and get a hug from Winona because she'll understand exactly what I'm talking about. So that being said, I just want to say that the Black Women's Health Project has designed and implemented a sister circle model that we use throughout all of our programming areas. So that includes areas like even violence prevention and even around, obviously, mental health and around, maternal health and all of the issues that really impact Black women. It's a sister circle model that is rooted, it's nationally recognized, it's rooted in evidence, and we utilize this practice as an engagement model for training Black women and increasing the community's capacity for service and healing and coming together and filling the gaps where the current systems are not adequate or fully resourced to provide us with the care that we need. So for mental health in particular, our program is called Sisters Mentally Mobilized. It's one of the most exciting things that we've developed. It is supported by the California Department of Public Health's California Reducing Disparities Project. And we are part of the African American cohort, but there are 5 population groups, including API, Latin America, Asian and Pacific Islanders, API, Native American, and LGBTQ. And so the racial and ethnic disparities that are faced around mental health have been cited by the state of California. $60 million has been invested in this project. It is intensely evaluated by Loyola Marymount University, and we are in a pilot project. We are in year 3 of a 5-year project. And so we have had a chance to, we were operating these sister circles and we utilized them as an engagement model and to train women to be advocates and to be navigators and to stand in the gap for themselves as they face and deal with the challenges of their own mental health, but also for their family and their friends in the community. We train Black women who are hairstylists to recognize signs and symptoms of depression, anxiety, and mental health disorders in their clients. Because in our community, we spend a great deal of time with our hairdresser. and if you're not African American, you might not know that. But the relationship, that's one that can last 20 years or more, okay? And your hairdresser has heard it all, felt it all in you, recognizes even issues and challenges as they exist in your hair and in your skin. Yes. So this peer model that we've designed is set up to create a safe space for women to come together, to share, to deal, to heal, to love, to cry, to anything that needs to happen in these spaces. We have a set of standards that we utilize where we use intensely cultural elements that set the atmosphere. Everything, I tell people, everything from the smell in the room is attended to. From what you see, what you hear, the utilization of music, the utilization of a combination of things that are deeply rooted in African and African American culture. Those are the elements that we use. And then we bring in licensed mental health professionals to provide the clinical training, the systems training. We bring in policy people to talk about what happens at the legislative level, where they can deal with local, regional, and statewide policy issues and address systems gaps. We also talk about the healthcare system and the provider side and where there are strengths and weaknesses in that area of care. We talk about the lack of diversity in the health professions, and that is a major challenge. So we support and encourage through pipeline efforts Black women who are trying to expand their capacity and their knowledge and their professional skills to specifically target our population. We create databases and we refine them constantly so that they're fresh and up to date, because sometimes you can find a person to provide a level of care and sometimes you cannot. Now, from a perinatal standpoint, some people in the room who I've talked to know that we are launching into refining our curriculum to address perinatal health. And we are going to pilot a training in the Inland Empire. I don't know if that means anything if you're out of state. Riverside and San Bernardino counties. There you are, the IE in the house. So we are going to pilot a program there. Right now, we do not have funding to support that. We are sort of pulling it together, with pieces, and we have a professional, Dr. Saida Prepad. I'm not sure if some of you may know her, and she is going to act as the facilitator for this training. And we are going to launch this training because obviously the areas of mental health that impact Black women, we could go on all day. The psychosocial stressors, the issues in our community, the challenges of what happens when we do face a mental health issue. Calling 911 is, that's an issue all by itself. Training the women to be there for each other, training them to build coping mechanisms within themselves, and then training them to recognize signs and symptoms and be ready to navigate and to mobilize in the community around these issues. So I could go into great detail about the model. One of the challenges that I do have with peer training and the peer model that the California is planning to implement, and hopefully it'll pass through the legislation, SB 10, is that, and you mentioned it in one of your slides, is that, and SAMHSA I think includes this, that the peer would have lived experience and a diagnosed mental health disorder. That is the challenge for us, because in our lives, for most of us, when we even write grants and say, does your board or your staff have lived experience? I'm like, we are the lived experience. It's impossible to be Black in America and not have the lived experience. It just is. It is. And so, but to have a diagnosed disorder, that is where, when we've written to the assembly person, and, it's like we challenge that piece of it, because if you live in a household, if you're dealing with it, I'm dealing with an issue right now, and having to help my family where we have not been able to find services through a Kaiser system, which I could go on all day on that one. And so, if you can be a peer and you can train and you can be trained and certified without having the diagnosed disorder. And that is where I would challenge, sort of the existing parameters.
That's a really great point. A really great point, and we should pick up on that more. Absolutely. It's hard to follow, Sonya, but I am going to take just a minute to talk about the other program that we were hoping would be able to join us today and just couldn't for a variety of reasons. It's called the Alma Program, and it's being piloted and launched in Colorado, and Alma means soul in Spanish. It's a program that is focused not solely for Latinas and the Latin cultures, but it is being piloted in two different Latina communities. But it's also being piloted in Kaiser, actually, in Colorado. Sorry, we'll talk about that later. And so the Alma program is a certified peer support specialist training. It's online, so the training happens online, and then there are coaches at the School of Psychology in Colorado, in Boulder, that are doing the coaching and the supervision and the reflective supervision with all of these peers. And then they're the anchor back to being able to help when there are issues or things that the peers need to discuss, and doing the bi-weekly, I think, follow-up calls with peers to see how things are going. Right now, the pilot is happening in 3 communities. One is a very rural community out in the Roaring Fork Valley of Colorado that is a Latina community or a Latino community of folks that may or may not be recent immigrants to the United States and work in agriculture and service industries in that part of the state. There's also a pilot happening in Denver in a community, a Latino community in Aurora, and it's being anchored by both the mental health center in Aurora and then also with an FQHC that these are the ways that the peers are being introduced to folks and working in the community. And then it's also being piloted in Kaiser in Colorado, and they're doing the research on sort of pre and post intervention and in more of a randomly controlled trial sort of environment. There's a 2-pager about Alma in your app, and you can learn more, and then we can always direct you to the folks that are working on that program as well. So we've heard about 3 different models. We've heard about the Women's Innovation Center in Arizona. We've talked about sister circles, and now I think it's important to hear from a peer herself. So Hasana, can you talk a little bit about the experience that you had that led you to become a peer, and then also the training that you went through to be a peer support specialist, and some of your experience in working with other women?
Well, first of all, I'm honored to be here, and I'm glad for all of you that are interested. Well, I was determined at 17 to have my first baby when I was 21, which I did accomplish that. But when I was 7 months pregnant, they told me that my baby was in distress, and they were ready to induce labor on me. So at the end of the ultrasound, the tech said, "That's enough of that." That was hurting the baby ears anyway. So then I started to cry before they took me down. I wanted to call my mom. But then when they took me to my room, and after I had spoke on the phone, called my mom, this doctor came and said, "We don't know what's the matter with you, but you are a high-risk patient, and you need to come in twice, every 2 weeks to be seen, and you can get dressed and go home." So I thought, if I had not started to cry or wanted to call my mom, they would have taken me straight down and induced labor on me. So when I got out of there, I never went back until I went in labor. And I didn't accept anything that they had to offer me because I was afraid. And so I say that the fear of what they had to offer was greater than my pain. So I had an undisturbed birth, and my daughter ended up just fine. 8 years later, I married, and within 14 years, I've had I was wounded by non-traumatizing miscarriages. So I am wounded, and that's what causes me to be who I am today. And I go by Hasana 9 Exchange, Hasana 9, but my company name is Hasana 9 Exchange because I'm always delighted to reach out to others and to do anything to help anyone. During that time, I've had all those miscarriages. I am an interior decorator, and I do custom window treatments and upholstery, and I have taken that knowledge and I use it holistically to help others that are wounded, through maybe colors that can help motivate them, or adding some of it in their home along with the other healing tools. So yeah, that's what I do.
Can you tell us a little bit about your training? What kind of training did you have?
Oh yeah. So that caused me to, to become a peer, to be able just to reach out. And a lot of the training that I had, where I had it at, it was more so dealing with like substance abuse and things of that nature, but I just used it pertaining to my area and how I can reach out to those that I connect with. So it's all the, the healing tools and the coping strategies and the unpacking, but I add that extra seasoning in there as far as being an interior decorator and, whatever can help this person come through. And then I am very open, and I have all types of stories, all kind, and, from different angles. So it's very easy for me to drop in, especially if someone's really going through trauma. I can really relate to them very well, and we can work it out. I can feel them. And I'm letting them know, if I haven't been there, I've been pretty close or past that, So, yeah, the training was good, but it dealt with a lot of the substance abuse, but still it's the same concept that can be taken and used for whatever, the problem may be.
Do you remember where was your training or who administered it?
It was with Share in Culver City. Yeah, it's a organization there, nonprofit organization there, and they deal with like housing, substance abuse, this and that, and they, help people.
Not letting you off the hook yet. I'm going to keep you talking.
That's okay.
So, is there a story of a woman that you've worked with as a peer that you could share kind of what that relationship was like?
It was really nice. I had flew to North Carolina to visit a family, and their daughter had just had a baby when we got there. So I was still there, when she came home. And she was having some issues, and one of them was, it was hard for her. She was complaining about feeding her baby, and, the baby, she couldn't get the baby to nurse. She really wanted to nurse the baby, but she didn't want to give it a bottle, but she was complaining that she could just, she was having some issues. So one of them, I was like, well, why don't you help him? And she was like, what do you mean? And I was like, well, first of all, your breast is so engorged. It's hard for him to latch on. So why don't you kind of like, get some of the milk out and, make the nipple stand out so that he can latch on. And then she was like, please don't leave. She wanted me to stay. But so, then I have others that are, just going through some trauma. I had a woman that had a baby and she hadn't touched him in 6 months. It's just she was having some issues and she just hadn't touched him. It was the other family members, and so, I talked to her, and, was trying to, connect with her. But I didn't live where she lived. Actually, this was in a whole nother place, and I couldn't stay. But, yeah, so it's definitely a need, and sometime to go and stay there a while, like stay with the person, depending on the severity of their problem.
Thank you, Hasana, and we're going to ask more questions in a little bit.
Okay.
So I have some questions for the panel, and then we're going to turn it over to all of you, and hopefully we'll ask some of the hard ones. So some of the things that have come up when talking about peer support is what are some of the risks around peer support, the risks and rewards, because there's probably both, right, in developing and operating a perinatal peer support program. And then how do you mitigate those risks? And when I say risks, some of the things that have come up are how do you make sure that a peer knows when somebody may need a higher level of support? You know, how do you make sure that you have the lifeline there for folks that maybe a peer is no longer the appropriate level of care? So maybe we'll start with Michelle and then have Sonya speak to that as well. And Lisa, also in your experience around the training, what that looks like and how you balance the risks and rewards.
For us, the biggest risk is, yes, knowing the scope or recognizing when I need to ensure that that higher level of care isn't implemented. And we really feel strongly in the supervision piece of it. And that's why we make the peers a part of our team. They attend all of the training. We offer, in our model, we offer extensive training beyond what they get with their peer support training and then their maternal mental health training, in addition to trauma work. But then we're in constant communication within our clinic with our peers. So that's, I think, essential in providing responsible care, because we don't want we don't want a peer to get in over her head and then have a tragedy or anything else come along with that. The rewards are, so in our area, we do have a lot of perinatal mental health certified therapists where we're really excited about that. Unfortunately, many of them don't accept insurance. And so we're one of the few organizations that our therapists all go through the perinatal mental health training, and then we'll be taking the tests for that. And we do accept insurance and bill the Medicaid plan. So in the process, in getting into a therapist, our peers step in and they bridge the gap. And they teach skills, they normalize the experience, and a mom doesn't have to wait 4 weeks, 6 weeks, 8 weeks to get in to see someone. Our peers will see someone within 2 days when they call. And that's unheard of. Or they'll see them bedside, which is even more exciting, right? So I think the rewards are that we can use them to meet moms where they're at when they reach out.
I want to say that this issue around the risk is something that we've been grappling with as we're building out our curriculum and our model for this pilot in the Inland Empire. And we've been talking very specifically about, one, that the opportunities for referring out, are a challenge. And so when we have women that are at a place where they need, either some direct treatment, like a psychiatrist, where they may need medication. We're trying to build a network of referrals, and that is a risk because you don't want to raise the expectations of someone that you can help them find care, and then you're dealing with this same issue that they're facing when they make the calls that they're unable to find care. So the Perinatal Mental Health Alliance, People of Color Alliance, is trying to build this database, around the country for professionals. But what we're finding is that we may have to embed a telehealth model into our program because there are people that we can reach by phone, and some have said, like, I will maintain a phone relationship for the program, but some of them are not here in California, and some of them are not located in the area where the women live. And so we're trying to think through what that looks like, as long as you have somebody to call, but they're liability concerns. And for us, the other risk is that when we can't reach someone, and we try to do our work in pairs. So we train women to mobilize in the community, and then they will work in pairs. So if you can't reach one, you can reach the other, or they'll show up together and work with we don't call them clients, but a sister. And so, you know, when you can't reach someone, we're even like concerned or about the risk of advising people of what to do. So the whole thing I mentioned before about dialing 911 and calling for help. And, you know, the feedback that we've received is that, you know, many women have experienced the loss of their children, the children that they already have, or the loss of, you know, sometimes in even a very aggravated situation when they call 911. I mean, I don't know, you know, how much you all know about this, but, you know, in the Black community, calling the police can sometimes result in your death. I mean, I'll just, you know, make it clear. And then anything before your death, you know, which is, you know, obviously, you know, extreme aggravation, potentially child services engagement, and then ending up in a institution. And we use the criminal justice system as a mental health provider in the state of California, and Los Angeles County in particular. So those are some of the risks that we really face, and we wonder about, you know, how do we, you know, we're standing in the gap, but we can't fill it completely, you know. And then how do we line up a number of professionals who will be at the ready when they're called upon to at least maybe provide, you know, some higher level intervention by phone. So that's one of the challenges. The rewards are numerous. I mean, we see women who embrace this idea of, you know, this group model of care coming together to be able to talk about the things that are challenging, and even finally realizing, like, I didn't recognize that as a mental health issue. I didn't realize that when I wake up in the middle of the night and I feel like somebody's stealing my baby, you know, I didn't realize it, and I run in to check on my twin daughters. You know, I did not think of that. You know, I just know that I'm startled and I'm sweating, and then the next day I'm tired and I keep thinking about it. And we talk about that, and we talk about intergenerational trauma. And so what this woman ultimately learned that I'm referring to is that her grandmother had an experience where her children were taken in the middle of the night. And so it was only talking that story out in a circle, and then she went back to talk to her family, and she learned. It may seem, you know, like, really, you know, but those are the things that are happening. And so people are living, you know, through, if you know about epigenetics and you know about, you know, this weathering that's happening, that you're living through the trauma, you know, even past generations, on top of the psychosocial stressors that, you know, we all deal with. In this room, all of us would deal with those things, the loss of a job, you know, the loss of a loved one, or a bad breakup, or, you know, but when you add, you know, these other layers of things, and, you know, the microaggressions you experience daily, you know, women come to these circles, and it's, right now we've trained about 325 women in the state of California, so Northern California around the state. And when you hear the testimonies, when you hear them, and you can go on our website and you can listen to some of them, you hear people talking about, like, how it has impacted them and their own experiences, and then how they now feel so equipped and ready to go out and to help and support another Black woman in the life that she's living, dealing with perinatal mental health issues, the ongoing mental health issues in her life, and those of her family and the community around her. So we talk about our circle. We say, I need the circle needs me, and the community needs the circle. The sister circle, that fictive kinship, that model of care and support and coming together, because that, for our culture, is how we connect. We are not an isolated people. We don't, that has, for us, that's more of a Western model of living. That's not the way we live. We cook together, live together, sew together, you know, pray together. There is an inordinate reliance on faith, and we do talk about that. You know, we're like, and somebody last night says, she told her friend, suck it up, buttercup, you know, you got things to do. And that stayed with me, because we always say, girl, you better get down on your knees, pray that away, and get up and get on with your life. But we know better. We know better, and we teach and we train women that faith is a supportive factor, but it's not the only one. And God created mental health professionals. So and we can use them.
You want to follow that, Lisa?
I don't know how I can follow that. But thinking back to your question about some of the risks, one of the things we heard about when we were talking to people who had gone through the training was if you're fortunate enough to get a job in a place like WHI or, where there are those supports and the clinical oversight, and that's a wonderful thing, but not everybody who went through the training landed that either in the short term or who knows, maybe it just wasn't. They ended up not working in that kind of environment, and yet the training, because it was focused on maternal mental health issues, did raise some issues, and there was sort of a little bit of feedback, well, now what, and what if this raised all this awareness of these issues, and I have no support now. So that's definitely something that we've talked about as building that into future trainings, of having some, whether it's availability of a check-in or giving people resources. It's certainly, a concern. Yeah, absolutely.
And with that, so in Phoenix, we have several peers that were not placed, right? And we have the work for them. It's just then figuring out, as we've heard all the last 2 days, the payment. And because we are in one hospital system already, and we've had another hospital system approach us on this as well, and we can bring our peers in for that, which would be amazing. We constantly stay in contact with those peers about how can we expand upon this, because it's so needed. So hopefully we'll be moving in that direction.
And then this is a little bit of a pivot, but when Sonya was talking about having the telemedicine, that one thing about with the pilot training on pilot testing of the training, the original peer support training was a 2-week dedicated in-person, live training, and for a lot of moms with young children, that just wasn't very practical, and so they developed a specific maternal mental health component that was distance learning, and I think that was really a big success. And the way it was implemented was also really ingenious, where you had somebody in the live training who could sort of build the bridge between the people who were doing it by distance and what was going on in the room. So I think that was an important lesson learned.
I don't think I'm telling tales out of school, but sometimes providers get threatened or there's friction around scopes of practice and bringing new providers into a field. So can we talk a little bit about if you've experienced any friction in introducing peer support into the community, and how you've been able to mitigate that, or work with provider groups around how we're all stronger together. Hasana, have you personally experienced any friction with other mental health providers or folks in the healthcare profession around being a peer and being out there in the community working with other women?
No, because I'm very independent. That's it.
Sonya? We'll just leave it at that.
I wish I could say that. But that's not always, that doesn't always work. So in our community, thank God, there is a light that's shining bright on doula care. And not bringing back, but even elevating, the care that midwives provide. And so we have seen some challenges in certain systems where, and we've seen this even across racial and ethnic lines. So I'm talking about even African American, clinicians who who have some challenges, with seeing either a doula or a midwife come in and provide, support for a Black birthing person. And so there's a lot of, in LA County and the Inland Empire right now, there is a growth of interest and understanding about the care that doulas can provide. And since many hospitals are now being made aware of that they are part of the issue around African American maternal and infant mortality, and that they have a role to play in that, and it's being highlighted, now there's beginning to be more conversations that say, well, let's see what we can do. And if a woman who doesn't feel comfortable sort of going to prenatal care, in certain settings, or goes and finds that 11 minutes is just not enough. Is it 11 or 7 or 12? Whatever. Somebody said 4. Not enough time, for you to get what you need. Then yes, the hospitals can now recognize that having a doula in the life of that mother can aid in bringing that mother to a birthing scenario where she's better equipped in that environment. She's also more knowledgeable to ask questions and to engage in her treatment and not be, sometimes people say, intimidated by what's happening in the clinical setting. So having a midwife there, now building relationships with the hospital systems, I think is going to help to address that issue. Because this scope of care, right now, there isn't enough that's going on to support Black mothers or Black, women in the perinatal space. There isn't enough. So in the meantime, until the systems can build the capacity to provide more care, and they probably won't, they probably need to just incorporate and embed doula care and midwife care into their models of care for, and I say specifically for Black women, until we reduce that disparity in such a way. And I do suggest often bifurcating the experiences of Black women in a hospital or in a clinical setting, because the disparities are so great that your traditional models of care are not going to reduce that gap, and have not for 40 years. And historically, we know in our community that midwives and doulas have, birthed our babies for generations, for hundreds of years, and we didn't see the mortality rate that we're seeing now, and that we see in third world countries.
I was going to ask a couple other folks to answer that question, but I want to make sure that we get questions from here and from folks that are watching across the country. So I think we have a few minutes for those, if I'm correct. And do we have a mic, or do you want people to pass questions? Okay.
Hi, you all are my heroes, Shiros. I love what you do. I do peer support. I'm a full-time volunteer. So I know you all touched on it a little bit, but with hopefully the peer support specialist becoming maternal mental health and billing, is that in group settings as well? Is that intended? Because for me, leading groups where I'm privileged enough to be able to do it without a fee, there are people that can't afford weekly just the meetings. That doesn't include prep time and debriefing time and being on Facebook and managing a group and talking to moms or going to their house or all of that. And is there a part of that that is intended for payment? Because people can't do this for free, and we can't expect these moms to keep, we've hit the max of asking these women to keep volunteering their time, but how do they get paid?
I'm really glad you brought that up. I was hoping payment was going to come up, so let's go there.
On that one.
Michelle, do you want to talk first about payment? Yeah.
So we most of our staff has volunteered a large amount of their time as well, and so we in particular changed our licensing of our facility so that we can bill for our peers, and it takes like an act of God and your DNA to get credentialed with some of the Medicaid plans in our state. However, we're in the process, but in the meantime, we've been able to get prior authorizations for our peers, and we have gotten paid for our peers, whether they've been on-site or off-site. And I mean, that takes a lot. So if you can get into a system, and that's what we want to do. We want to create a system like this that can go out into the communities and make this happen. We know it's working, and we're making a difference. So we need to make it happen now, because we can't expect our peers to continue to give our times, or else we'll be all flat on our face saying, okay, I'm fine, I'm fine, I'm fine.
Are there online training modules for perinatal peers that can be accessed outside of these programs, particularly ones for Latinas? And then somewhat related, for the project, Lisa, that you mentioned, what kind of supervision was provided?
I can talk about the Latina one. I would definitely get in contact with the folks that developed Alma. Again, their contact information should be in the app, because it is an online Spanish, completely in Spanish, for Spanish-speaking women and individuals. And so I think that would be a good resource for you. And then I forget the rest of the question, but it was Lisa.
So the question was about supervision. So we, like I said, we provided online contact and then group contact with the peers as they went through their training. Our initial group that went to the 2-week in-person experience had something come up that was not, it was because of the vast array of differences amongst the peers. There was a pretty traumatic event that came up. So then I provided the supervision to debrief that event as well. And our organization provided continual contact to the peers. But then we brought on peers as our employees. So then they were provided that.
Well, I just wanted to offer support. I ran a peer program for over 10 years in California, and there's actually quite a bit of funding through PMH-C funding, Mental Health Services Act funding, and specialty mental health definitely covers peer support. So I also worked with law enforcement. I developed a crisis intervention training for peers, as well as a mental health crisis call brochure that's been published throughout California. So if anybody wants information about peer support in California, I'm happy to speak to that.
My question's for Lisa. Really in the terms of research and evidence-based practice and what you would suggest. I'm here for Secure Beginnings. We currently have a parent care program where we have volunteers going into the homes up to 4 hours a week during that perinatal period. And so I'm really interested in how we can get more efficacy and how we can find those partnerships for research, especially for grants and funding.
There's definitely work in this area in the scientific literature. So you might want to start there by just seeing what's out there that's relevant to your work. And I know SAMHSA supports a lot of They have grants around recovery support that may not be specifically about maternal mental health, but they would certainly apply.
In Arizona, one of the organizations that works primarily with peer supports just received a SAMHSA grant to train peers as doulas. And then they're going to provide the maternal mental health. We're going to do the maternal mental health part of their training. And so it's for the SMI population and substance using population, which is amazing because that added support is invaluable. So there's a lot of work going on in that.
There's a suggestion that we also continue this conversation on the app, especially people that are sharing resources because it's so rich. I'm going to go here.
Hello, thank you for all of your comments. I've been working with the Department of Public Health here around the Office of Violence Prevention, around a peer initiative, cross-sector, not particularly mental health or maternal mental health. And one issue that has become quite concerning to us is that we see most supervision of peers is done by licensed mental health in a mental health model, whether it's social work or as an MFT or whatever it is, not in a peer model. And there is significant difference between a peer model and a mental health model. And I'm wondering, how are you addressing this and not turning peers into mini clinicians? To which to say is they don't have the training for it, and so it puts them in a very precarious position and it diminishes what is their big skill, which is the lived experience.
That's an excellent question. I don't know who wants to take it first, and then I can share a little bit about, they've been struggling with that in Colorado too, as they develop this Latina model. Where is the right anchor, right? Where is the right hub and the right home for peer support specialists so that it isn't actually a part of the mental health system in Colorado, but it really is of and for and by the community. And so I do think there is a lot. This is a perpetual question of what's the right connection point and what's the right space to make sure that you do have that touch point back to expanded care if you need it, but also respecting the program for what it is and what its real benefits are. So Hasana, please.
I think that individuals should seek out maybe independent peers or independent doulas that have the lived experience that is best fitting their situation. I think that would be a great help, because otherwise it's like altered when you're dealing through the mental health or, the other organizations. Your best bet is to look independently for independent peer or doula.
That is an interesting dynamic, because one of the things that we focus on is that our model is very PEI focused and prevention and early intervention focused, and that we're training women through this sister circle model, and the sister circles continue. So once the women complete the training, then they operate a sister circle that's ongoing and existing in the community. And the reason why we are not yet pursuing any certified training, even though we know that there isn't a standard model for California as of yet, but is because we want to be careful not to, mix up, sort of like the provision of mental health care. And the way we're addressing that is that's why we focus on the pipeline work of trying to increase diversity in the professions, encouraging people to, add perinatal mental health training as a part of their existing competencies, using the, telehealth models or ways to get the training, through other sources, and even training doulas, to have the knowledge and experience around mental health, to recognize that, and even midwives. Historically, you can operate from the space of lived experience, but you cannot attempt to stand in the gap as a mental health provider. And we are so serious about that, because as the women doing this work, we already have enough burdens. We can't take on now, something that could potentially even be a liability issue for us, and not to mention a guilt issue and those things, because you can't be a replacement. You're just in the gap and assisting and navigating someone to get the higher level of care if they need that.
Time. Oh, I knew we were going to run out of time, but thank you everyone very much, and thank you to the panel. It was wonderful.